All right. Well, I hope you had a great discussion. I know the time was not enough. When a lot of people come together, it becomes chaotic. But that's when the great ideas happen. Let's continue the discussion further. This is our LinkedIn group. Gilbert, can you? This is our website, and our next meeting is on January 9th. We meet the second Wednesday of each month from 6 to 8 p.m. This is the first time we got together. I'm expecting the crowd to grow bigger. I reached out to Microsoft Nerd, and let's see if they can offer us a space. Gilbert, can you please point out to that? If you see here, we have our Facebook, Twitter, and LinkedIn. We're going to continue our discussion on LinkedIn. I know most of you didn't have enough time to continue and come to a conclusion, but let's summarize whatever we talked about, and we can continue the discussion on LinkedIn. I'm also going to share a Google Doc. I highly encourage each one of you to reach out to other people to collaborate. If there's anything I can do to help you, if there's anything I can do to connect you to other people in the healthcare, look at my LinkedIn profile, and I'll be happy to do so. So okay, Gilbert, can you please click on the LinkedIn, this icon? So this is our LinkedIn page. I highly recommend you to come here and continue the discussions further. So let's get started with our first group. Patient experience, profitable business models, and health insurance card connected to the ATM card. Who would like to summarize the discussion?
Okay. Thanks, Noel.
Sure.
So,
Tell us your name again.
my name is Chris Harrett, and we kind of combined all those topics and had a kind of wide-ranging discussion about business models and healthcare. We had one colleague from Germany who helped us understand why the Germans live longer and pay less for insurance than we do. We talked about a lot of different ways people would, services people got, not just in medicine, but other things related to health. But I think that what came out of it, this interesting summary, was all the different revenue streams that can flow into a healthcare company. I mean, there's the obvious one of selling fee-for-service, which is a model that maybe be going extinct in the United States. But so if you're just going to look at the different revenue streams that might come into a business, whether you're providing health care directly or you're selling technology to healthcare providers, there's getting reimbursed from the insurance company. That's the old one. But there's also getting the patient to pay directly, things like concierge medicine services or health-related wellness services. There's getting employers to pay to keep their employees healthy, helping organizations avoid costs, whether it's readmissions or office or supplies or whatever. There's advertising. It turns out quite a few businesses supported by advertising. But one of the most surprising ones actually was selling the data. And that's one of those sort of parts of a lot of business models it's not obvious, but we started to uncover stories about companies where they appear to be in one business, but what they're really doing is gathering data on patients or on consumption or whatever, and then monetizing that somewhere else.
Hold on, Chris. Does anyone have anything to add to Chris's summary?
That's what pharmaceutical companies do with clinical trials. They get the actual data. They may not get patient names in terms of trials and stuff. And then they pretty much collect that data and monetize it in ways that gets it.
That would be the granddaddy of all of these.
It's actually called big data.
Yeah.
Are we referring to economy on Monday, transition in healthcare? They were discussing big data, and that's nothing else. The data is neither big nor hugely interesting, but it's extremely valuable. It's just finding ways to basically extrapolate this data, which is basically existing, but to somehow capture it. That's basically the whole concept behind it. As simple as that.
Thank you, Chris. Where's that next? People from Sao Paulo, sorry, Caracas. Digital, what were you talking about?
We were over here.
Oh,
It's
sorry.
in my,
Raghu and Yuri. Well, who wants to summarize from your group? Simon? Satish?
Satish was there.
Anyone would like to summarize?
I'll go ahead.
All right.
I'll give it a shot. Okay, we thought about the problems with the information not being in different silos at each places. It was experience from you go to a hospital and you check in an ER. They don't have any information about you because you normally go to a different hospital, and then one of the I think it was you who pointed out, you take your car to a car dealership, and then you used to go to, I'm sorry.
You might want to summarize what was the topic and then discuss, because people
Sure.
are lost.
Sure, sorry. We were lost, so that I'll try to. The topic we were trying to discuss is why can't there be a system where the information gets exchanged freely so that it's available at least in a geographic area for where the patient goes in, it's available for the doctors to treat, and not necessarily trying to reinvent the whole. So that was the problem we were trying to discuss, and one of the technologies. The conclusion was the technology is already there, because you take your car to a dealership and you take it to a different dealership. They know what repairs was done in the other. So why can't? And they know a lot about your car, but not about yourself. So that was the gist of the discussion. But again, it all came back to why it's not the technology problem. It's a process, security, privacy. It's a whole lot of different issues. It's not as simple as let's make it, all common technology on a common framework. Not as simple as that. It's like, there's HIPAA regulations, there's regulatory factors that come in play, there's different EMR systems which went off in different tangent by themselves. Economy comes in place. They don't want to share data because if you share data with a different doctor, and what happens if the patient likes that doctor instead of you? So there was a lot of other factors that came in place, and we discussed different factors that came in place to prevent actually what is supposed to be a more commonsensical way of dealing with the problem, so that it helps the patient in the end, rather than the whole other players within the healthcare systems. So that's what we discussed.
Thank you. Does anyone have any comments, suggestions to Raghu and his team's discussion?
I think one kind of interesting thing that comes out of everything that we're talking about, it's obvious, but even if the HIE comes about and all the data flows through it and you can move data from one clinician to another, if you're talking about, say, big data, or maybe it's not big, but data analysis, you still actually can't do it, because the data technically still belongs to that patient and can only be sent over to another clinician that's using it for that patient. No entity can actually go in there and take all the data that's been collected and analyze it. That legally isn't possible. So it's still a problem in the entire industry, or maybe it's opportunity in the entire industry, to collect data, aggregate it, because you can do that as a company. You can aggregate your own data and anonymize it and then figure stuff out from that. So it still is this play of who can access as much data as they can that's useful and come up with something from that. And the HIEs don't solve that at all, really, when you think about it. And I don't know whether they should or not, because actually that enables some very interesting opportunities in the industry. But then again, if we did have access to all this data, maybe that would enable some other kinds of, from the health point of view, maybe it would be the best thing. But there isn't, practically speaking, in any way to do that. So I think it's a kind of interesting ramification of the way that this data is actually being shared.
I think we need to begin to collect the data and make it accessible. I mean, there's, as I said earlier, the ubiquitous internet. If we all had a URL that we could point to that could grab, where your recent CAT scans or X-rays or, blood work, chemistry numbers, and the tools to collect the data and store it are out there. And the problem is, what's the motivation to do it? Who's going to do this? What is the motivation? And we had a discussion whether it's the government is the motivation, or is it, some other, free enterprise or whatever. But I mean, the technology is there. The question is, where's the motivation to do this patient-centered, record keeping? I think it's a real problem.
It's not about the patient. I said it's not about the patient.
But it should be, really.
Yeah. Well,
Yeah.
I guess that's what
But
we
that's where
agree
it's
upon.
going. It's going to shift from the provider to the patient. That's the whole model moving forward. That's ultimately what we'll end up.
That makes for a good segue for our group, if you don't mind. I'm Deb Cooper, and we talked about learning in healthcare, which is a nice, small, defined problem, right? Well, we started talking about it from each of our perspectives, from a nurse and a patient perspective, from an analytics and data-centric perspective, from a physician's perspective, about how hard it is for organizations to change, how difficult it is to communicate information along the continuum of care. And we were getting really frustrated as we went around in circles. But finally we had an epiphany, which is that having both the data and the stories is what makes it powerful. So, can I repeat your stories? So Danny had a story of how, from some of the work he does, that two of his examples are, he has six physicians who work with him. How does he make sure that they're all on the same page and working off of the same information? And if he were ever to not be able to communicate, how could he ensure that healthcare providers had access to his history? Well, those stories were really powerful, and we started talking about how along the continuum of care, each stakeholder could reinterpret it from their perspective. So what does it mean to be one of those six physicians? What does it mean to be a EMT showing up to see an unconscious patient? What does it mean to try and interpret a story from all these digital artifacts? So it really just comes back to patient-centered outcomes. If you put the patient at the center, everything else makes sense.
Thank you, Deb. Does anyone have any contribution to Deb's? Anybody?
I think at the end of the day, it's the economy that rules. So if there is, even in our discussion, we figured it's not patient-centric yet because there's no money to be made and everybody is looking after their own interest, whether it's the payers or the providers, and, So the economics, unless we prove there is a economies to scale to make it patient-centric, we are always going to have this problem. We somehow, I think the problem should start from there. In a free market economy that we
So
are,
changing incentives so that patient-centric is more rewarding,
is more rewarding
than
than
not being patient-centric.
Yeah.
Exactly.
This is actually happening right now. CMS actually just introduced, I think in the third quarter, these like value-based incentives. So I think we are shifting, or the system itself in the US is shifting more towards value-based care. But I think overall, until it's literally fully incorporated in the entire delivery system, it will take time. This doesn't happen overnight. But I think the initial steps, the initial incentives are in place in order to change or move forward to a more talent-based oriented system.
I think what Raghu is trying to say is that the motivation to kind of move in that direction is not there, because
But I'm
They-
saying, I think
even
that there
though
are,
the mandates are kind of being created, and like there's some guideline,
Well, that's,
but
it's the
individuals.
concept of the tipping point, enough needs to change in that direction so that the tipping point is reached, in which case you have to proceed in the new direction.
Right.
So we're hitting 8 o'clock.
All right, I would like to wrap this up. Does anyone have any objections to add your email address to the mailing list? Anybody? You're fine to be on the mailing list? Okay. Our next event is on January 9th. We're going to meet every second Wednesday of each month from 6 to 8. I'm also looking for volunteers to run the meeting. I'm looking for volunteers for marketing, and event coordination, and transcription. Please come talk to me if you are interested. I want to thank two of our volunteers tonight, Pabani and Kairi. And I also want to thank my co-organizer Danny, as well as Eli. Well, that's all I had to say.
I want to add one thing.
Sure.
When we, if you have suggestions about how this could have been better, this is a very organic process. Please feel free to communicate that on the LinkedIn site. This was awful confusing, it would be better if, and really, if you have the suggestion about how to do it better, that's really what we're looking for.
Yeah.
Because this was a big experiment, which I personally think was tremendously successful, but it can always be better. Continual learning.
Thank you, Danny.
That's all.
And this whole purpose of the meeting was to bring people together.
Yeah. Okay, thank you.
So,
Very forgiving.
No, but I'm saying it's a good starting
Yeah.
point. It's a really complex system, so I mean,
Yeah.
the areas that were addressed, I think, were good areas.
I thought it was pretty amazing that we started with 12 different stickies up there, and we ended up with, 3 groups?
Yeah.
That was good. Because,
I just want to wrap it up. My whole purpose was to bring people together so that they can collaborate, share knowledge, and do something with these ideas. So please join the LinkedIn group and further the discussions and make connections. Well, one last thing, my blood glucose level is low, I don't know about yours, so we're going to have some pizza. Thank you.